Gillingham, your Surgeon General here, and welcome to the debut of our series in which we are going to have in-depth discussions with authors from the books that are on the Surgeon General's reading list. I think for many of you, I've shared that I'm an avid reader. I find that keeping up a schedule of reading on topics outside of my area of expertise has been very beneficial. I think everyone knows in the Surgeon General's reading list, we've paired books to each of the 4 strategic goals for Navy medicine. These are books that made a particular impact on me. These are not assigned reading; these are opportunities, as I've said. So if you see something that sparks your interest, I'd highly recommend that you dive in. We've made that, our public affairs folks have made that very easy because the majority of the books are available on the Navy MWR Overdrive site, and there is a section related to the SG's reading list. We'll do hopefully be able to do a series of these, but I'm more than thrilled to be able to announce that Dr. Mohammad Azaman has graciously agreed to be our debut author. He's the author of the Biography of Resistance, the epic battle between people and pathogens. It's an outstanding read and a combination of microbiology that even an orthopedic surgeon can understand, as well as some great history, some of which, frankly, there are some specific references to Navy and military medicine that I found particularly interesting. And so at this point, I'd like to introduce Dr. Zaman. He is the Howard Hughes Medical Institute Professor of Biomedical Engineering and International Health at Boston University. He's won numerous awards for his research and teaching, and most recently was named Howard Hughes Professor by the Howard Hughes Medical Institute and elected as a Fellow of the American Institute of Biological and Medical Engineering, which is a very high honor. In addition to that very busy research schedule, he is currently involved in setting up biomedical engineering departments at universities in Kenya, Zambia, Uganda, and Ethiopia. He's co-director of the UN Biomedical Initiative. And as I mentioned, the book we'll be discussing today is A Biography of Resistance, the Epic Battle Between People and Pathogens. I think those of us in the medical field know that antibiotic resistance is an ongoing problem. It's not new, and that resistant bacteria, developed soon after the discovery and first therapeutic use of antibiotics. And so, even as we really have our laser focus on our response to COVID, we can't lose sight that there's a significant public health issue out there in terms of emerging and increasing antibiotic resistance, and that it is, in fact, a significant contributor to disease, death, and costs resulting from hospital-acquired and community-acquired infections, for that matter. I think we all understand that in many cases, the antibiotic resistance is a result of overprescription by healthcare providers, perhaps improper use by patients. But as you'll find in the book, that there are actually many other sources of antibiotic resistance, and I'm hoping that Dr. Zaman will develop and explain some of those for us. So with that, I'd like to welcome Dr. Zaman. And sir, if you could, just share your background and how was it that you became interested in this topic?
Thank you so much, Admiral Gillingham. It's a real honor. And before I talk about my own journey, I'll tell the colleagues who are listening the story I was telling you. When I started researching for the book, among the very first people, and I'm not talking about the first 10 people, I'm talking about the first 3 people I contacted was a naval medical historian with the name of Andrei Sobochinsky. And Andrei was beyond helpful. I mean, helpful wouldn't do justice to what Andrei did. Not only, and here I was, not as a historian, had never been to US archives before. Andrei sat me down and really sort of told me how to sort of go about doing this, not just in naval medicine, but in sort of just in general. And over the course of writing of the book, he really sort of used his real and proverbial Rolodex and connected me with people at Walter Reed and in the sort of CDC and beyond. So I'm truly honored that I have the opportunity to talk to colleagues in uniform today and beyond. I grew up in Pakistan, in a country which is one of the largest countries in terms of population, about 210 million people. And I grew up in an upper middle class family or middle class family. And for us, antibiotics, and unfortunately it's still true, were taken for granted. You have a cough, you take an antibiotic, things are available over the counter, no prescription needed. And I never really thought of this as an issue growing up. You thought that this is something that you do. It's no different from aspirin or Tylenol or something. Much later in my career, when I was working on the issue of substandard and counterfeit and fake medicines, it turned out that antibiotics were the largest class of that, of poor quality medicine that are available all over the world. This was the same time when I was thinking about writing for a broad general audience. So like you, I like to read all the way from South African crime fiction to sort of Roman history. So really, I just have deep reverence for the written word and enjoy, and I'm fascinated by it. So I wanted to write something that was different, that was not rich only in rigorous and academic sense, but also that could be used by my daughter's 6th grade teacher, my neighbor, my aunt, and really sort of at a time when science literacy is all the more important. This was an opportunity to do that. So my own research on one hand was looking at why antibiotics are fake and substandard in large parts of the world, looking at this sort of emerging and rapidly evolving threat of antimicrobial resistance, but also telling the story of how we got here. I come from a family of historians. My brother, my father, my sister all have been historians, my mother as well. And I have the deep respect of sort of learning from the past. And as I started working in this area, I realized that many of the things that got us here are exactly what can get us out of it as well, right? So it's sort of not a single silver bullet. The solution is not going to come from my lab or somebody else's new drug, whether it is a large company or a small one, but a collective human effort across nations, across disciplines. And so that's how the whole story emerged. And I've tried to write it as a biography of how this whole thing emerges, and one that in many ways is still unfolding. So it's writing of a story that is very much is unfolding, and a story in which all of us are part of that.
Very well. That's terrific. And so, as I mentioned, I think most are aware of overprescription. A patient comes in and, the expedient thing to do is to give them an antibiotic prescription for an upper respiratory infection that is most likely viral, for example, and in terms of compliance as being contributors. But you speak to other sources of antibiotic resistance. If you wouldn't mind expounding on some of those for the audience.
Sure. So again, let's think about this in a simple way. The issue of antibiotic resistance, Admiral Gillingham, is actually as old as the bacteria itself. It's 3 or 4 billion years old. Now, most of our early antibiotics in the last century came from bacteria. Now, bacteria have been making these from the very beginning, right? So in the evolutionary war, a bacteria figures out or gets lucky and has an antibiotic and starts to really get a competitive advantage over its competition. Now, the other bacteria are not just going to die just like that. They have their own way of responding. So they come up with a way of developing resistance. And that's the reason you don't have one kind of bacteria. Otherwise, there would only be one bacteria that had the antibiotic and everything else would be over. The fact that you have this tremendous diversity in the bacterial world is because there's a constant tension and a constant tug of war going on. So I think many of us, including in sciences, think that antibiotic resistance is a new phenomenon. It's not. It's the equilibrium that human behavior has changed. One of the things that I talk about in the book is this sort of 2 wonderful scientists, one from Canada and one from the US, who go deep into the New Mexico cave system and scoop up the dirt from a cave system that has never been touched by humans, and there they find bacteria that are resistant to some of the third and fourth generation antibiotics. And that tells you that this has been happening from the very beginning. Or sort of uncontacted tribes at the border of Venezuela and Brazil, and if you collect their fecal samples, you see again signs of resistance. So resistance has been going on for a long time. What has changed in the last, I would say, 90 years is this sort of human behavior. So you touched upon overprescription, and I have to say all of us are responsible. The kid has a sore throat, and you nudge the doctor maybe to give antibiotic when it might just be viral, and the doctor also is cognizant that if he or she doesn't do it, the patient will go to the doctor down the street who might, right? So that's happening. You're supposed to take it for 3 days. You took it for a day because the fever is down and you're feeling fine. That's the other sort of the patient aspect of it. But there are other aspects as well. So large-scale use in the agricultural sector, right? So you have this issue where they're used both as a prophylactic as well as in animal feed. This is certainly the case in China, in Brazil, in the United States, countries with large sort of agriculture in the veterinary sector. So that's another dimension that is important. In many parts of the world, people take it, as I mentioned, growing up in Pakistan, over the counter, and they would take it as they need and not worry for prescription. And again, then in many parts of the world where the infrastructure is collapses, either because of the state collapse or because of conflict, what ends up happening is that you have a medical system that is fragile. And anytime you take out the doctors, anytime you take out the ability for that system to be able to test for antibiotic resistance, people will give antibiotics broadly speaking, right? So you see that in Iraq, you see that in Venezuela, you see that in Ukraine, you see that in Afghanistan as well. And that element, which might be of interest to our colleagues in the Navy, of how conflict and antibiotic resistance have been part of this spectrum might be of interest. One other thing which I think we don't appreciate as much is the fact that, like COVID, it's hard to really confine it to a single place. The book starts with the story of a 70-something old woman who sort of slipped and sort of had a hip infection, and the resistance wouldn't go away, to the point that she comes back to Nevada in sort of the western edge of the state, and there she is treated by doctors who give her every single antibiotic that is approved by CDC, 24 of those, and they couldn't save her life. And the infection was developed elsewhere. So the fact is that this is a problem where we cannot sort of have one country approach. We really have to be in this together. In many ways, very similar to COVID, is also something to reflect. So it's a human driven challenge, but one that has to do with human behavior, with sort of agriculture, with conflict, with sort of international travel, all of these things sort of coming together, as you had mentioned earlier, sort of a perfect storm of things.
So thank you for that. You actually nicely summarized your book there, so I appreciate that. And I would say to the potential readers that the individual chapters are vignettes that all come together to tell this story. If you given 2020 hindsight and looking back, so in the 30s and 40s, as sulfa related antibiotics and penicillin were coming online, and kind of in that golden era of the 40s and 50s that you described, what could we have done differently? If you had a man one could go back, what would you have recommended?
That's a great question, and one which I think is an important realization. One of the things that I would do is I would listen to some of the clarion callers early on. Right after the famous Nobel Prize speech given by Sir Alexander Fleming, there was this outstanding British doctor. Her name was Mary Barber, and she saw widespread resistance to penicillin early on. And so in a paper that is only about a page and a half long, she really points to robust data and saying, look, there's a problem here. So I think I would be, if I were to go back, pay attention to not sort of just the honeymoon period and sort of get carried away with the excitement, but pay attention to these clarion callers who are saying, look, there's a problem here, right? And you know, I was taught by my mother of taking the middle path, the modest road, and that's exactly what we should have thought about. And what that means is that nobody should argue that we should stop using antibiotics altogether, because I think that's dangerous. Even in the animal sector, if an animal has an infection, you should give the animal an antibiotic. But using it to promote growth is where the problem is, right? So I think some of the earlier doctors, there was a gentleman named Max Finland, based here in Boston, who would sort of write these long editorials in the New England Journal of Medicine talking about the problem, and this is even before MRSA became an issue in the United States. So I think that's what I would pay attention to, and sort of have a stronger regulatory mechanism with doctors and regulators, whether it is FDA or CDC and others, to look at that. So that's the first thing. The second one, I think now we know, and I wish we had known that in the 40s and 50s, of how tremendously interconnected the world is. Even before the world was this small, an outbreak in Australia could quickly become an outbreak in Canada and Denmark and India. Even before we had sort of these sort of flights that would go every day around the world several times. And that sense that we are in this together, I think would have been tremendously helpful. And the third one, in which I think United Kingdom did better, and Scandinavia did even more so, was more careful observation with the animal agriculture. And that's where US was much later than, for example, UK or Scandinavia was.
That no, I was particularly taken by that, and I was surprised in your description of the use of antibiotics in salmon, in the salmon farms, where you described the development of a vaccine. And so is that a potential pathway going forward?
Yeah. So the story of salmon is actually very interesting. I mean, Norwegian sort of salmon that is available in your sort of nearest grocery store has been a main cash crop for them for a very long period of time. And it was in the late 70s and 80s that they realized that there are specific diseases. And so if you look at some of those movies, they were using these large-scale cement mixers to put antibiotics and dump them in these salmon farms, to the point that the water had started to become black. And that was unconscionable for many people as to what exactly is happening to the environment, and this is not right. So that really in many ways pushed the vaccine idea and has really worked wonders. So vaccines in general have been I think powerful now. Granted that you won't have a vaccine for everything, that's just the nature of immunology, that you cannot imagine that there will be a vaccine for every single challenge that you're seeing, but sort of pushing hard on alternatives, whether it is vaccine, whether it is phage therapy, whether it is rational use of antibiotics, whether it is, and that's where I think our opportunity lies, as opposed to an imagination where one silver bullet will solve all of the problems.
Very well, and you mentioned phage therapy, and you may or may not know that our Navy Medical Research Command has been very involved in development of phage therapy, and so where do you see the future of that? Do you see that as an emerging area?
Absolutely. So the phage, again, I'm glad you mentioned. I spoke to colleagues who've been involved in phage work with Navy, both, and I spoke to some of the colleagues who were in South America, in Brazil and Peru and elsewhere as well. I think phage is very, very interesting. Of course, it's a science where I think post-COVID, there is a lot more interest in viruses in general. So there's an opportunity to understand virology and sort of the behavior of viruses. So I think that's interesting. And I think the other part of phage, which is important, is that it might be an opportunity, again, as I said, to come up with one other alternative. So you have phages, you have vaccines, you have better behavior, you have some antibiotics that are used more sparingly, and sort of creating sort of these multiple fronts of that might be one where we might have that. I do not think that phage is going to completely replace antibiotics, at least not in the short time, because the clinical trials have been very few for it to have that kind of evidence. There are some promising ones, but we just haven't had that many to do that. But I think the promise is certainly there, and there's a good body of evidence demonstrating that promise. And I wouldn't say I'm very familiar, but I've spoken to some colleagues in the naval medicine units working on phage, and that certainly is quite exciting.
Oh, very good. And I guess the natural follow-on would be, and you mentioned it, it has been very apparent to me that the focus on COVID, that there has been, a lot of funding now going to diagnostics and therapeutics and understanding of viral disease in general. And I do think that one of the silver linings will be an increased emphasis and a dividend, if you will, on understanding viruses going forward. Where do you see the major advances coming in virology?
So that's a great question. I'll take a step back. When I first was writing a book, I was talking to colleagues, and there was a point when a friend of mine commented that in sort of community hospitals in Detroit, you couldn't find enough residents who would go into infectious diseases. So infectious diseases was not something where your young, bright men and women went. I think that continued to be a challenge for a long time. People would go in cancer or neuroscience or whatever, but infectious disease was not sort of at the top of that list. And I think that is going to change. I think people are recognizing how important it is to have rigorous research and scholarship in infectious diseases that had been on the decline, particularly in communities which are high density, where you have lots of people with different socioeconomic backgrounds and things like that. So that's one thing that I think is a positive outcome of that. And with that, there will be more money and more research. So that's one. In my own area of biomedical engineering, there is exponential growth of the idea of point of care diagnostics, right? To be able to do these things at the point of care. And I think in some ways, the military, not just in the United States, but elsewhere, is cognizant of that in the field, you don't have the resources that you may have at Walter Reed. You do not have the resources that you have in a central hospital. So how do you really sort of tackle these new and emerging challenges in a way that is fast, that is accurate, that is robust, and that is easy to use without extensive training? So that's an area where I think the investments are going to be good. And I think in general, as we celebrate the new stories of vaccines, the broader emphasis on vaccines, and I mean, if you look at the history of vaccines here, getting something to phase 3 or 4 in a period of 7 or 10 months and having these rates of 90, 95, that's just as good as it gets. So whether these are mRNA vaccines or whether these are sort of other approaches, that itself, I think, is a wonderful thing. Does it mean that we don't have challenges? Of course not. I mean, I think we are dealing with sort of social issues of vaccine denial. We will have to look at logistical issues of cold chain, all of that. But I think those 2 or 3 things, on one end, basic science and vaccinology, and on the other hand, sort of the diagnostics part are certainly exciting. And the diagnostics one for antimicrobial resistance is critical, because part of the reason you have over prescription is exactly what you said in the beginning. That is, you have a fever and you assume the upper respiratory infection is automatically a bacterial one without really doing anything. Mm-hmm. So a diagnostic that sort of is able to differentiate between whether it is a viral one or it's a common cold, or whether it is a real bacterial infection, and whether it is one that is resistant or not, that would be phenomenal in terms of the prudent use of the antibiotics.
Well, that's exciting. And I agree, and just to build on that, as you probably know, we send out some very talented enlisted corpsmen, known as independent duty corpsmen, who serve aboard ship, and they are truly isolated. They're often thousands of miles away from higher levels of care. So the ability to do that type of point of care testing to help guide their treatment will be enormously valuable, as it will be for our Marine Corps units. They're often out in the field. So thank you. Now, it is interesting as a biomedical engineer that clearly you have a very compelling interest in history, and so how do you use that knowledge and that interest in history to guide your work?
Uh, it's sort of really integrated in ways that are just it's really hard to separate for me anymore. It was that these were in silos, not anymore, sir. Partly because I think one of the greatest lessons writing this book and others has been the hubris that somehow we are smarter than those who came 50 or 100 years ago. And I think that's just not true. Their ideas were just as important, as brilliant, as original. They had thought about similar questions. Technology might be different. My neighborhood looked different today than it did 100 years ago. But that has nothing to do with the fact that people weren't sharp or people weren't as thoughtful. So I think in some ways, history allows us to search for answers that people may already have answered, and it gives you a tremendous sense of humility. In this context in the book, many of the things that I'm saying today, many of the things that other people have said, people were saying all along. And it's sort of, in some ways, it is necessary to revise and repeat and pay attention, but also think about why we didn't heed their calls early on. So in some ways, it's a lesson, it's a sober lesson for all of us. And I think that's true not just in biomedical engineering and in microbiology, but in human behavior and sort of in our interactions with others anyway. So while some of the technology that I use today may not be there 20 years from now, and certainly was not there 20 years ago, but I think it's the tool set, the intellectual tool set that we have to reflect upon, and that certainly is very exciting. The other side of the history argument is that I think all of us like to read and hear good stories, and the stories of history are just fascinating. Fiction sometimes doesn't do a good enough job as fact, and other things do. So I think it's a pleasure to write. It's a pleasure to know. It's a pleasure to learn in that regard.
Well, thank you, and that's a great segue for my request that the story of Dr. King Holmes, Lieutenant King Holmes, who was a Navy lieutenant and made some important contributions.
Absolutely. So before I tell the story of sort of Lieutenant King Holmes, I'll tell you that even before I knew that he was in the Navy, I knew him because of his tremendous work in global health. So he's sort of the one of these larger than life characters who really established the field of modern global health, particularly at the University of Washington, but nationally as well, right? So he's sort of just a delightful character, but a father figure who has shaped the careers of many people. Some of his students, one of his former students was most recently the Minister of Health in Peru. So his impact goes well beyond many areas. So King Holmes, before he was a professor at the University of Washington, he had gone to Harvard as an undergrad and at Weill Cornell for medical school, and was a resident at Vanderbilt. So this is the time of Vietnam. He gets a call from Captain Stockline. So, and he said, well, King, we are going to sort of recruit you given the state that the country is in. And he was offered a job in Mojave Desert. And King said, that's not interesting, right? He said that in sort of 2 years, I'm willing to. So King is like one of these characters who are just sort of love to negotiate. He said, okay, get me to a better place where I can learn some real infectious disease. And what you get in return is instead of 2, I'll work for 3. So that's the deal that he struck, right? So he's sent on to Pearl Harbor on the very famous sort of vessel, USS Enterprise, right? So he ends up on USS Enterprise, and by stroke of luck in Hawaii, he finds a former mentor of his from Harvard, whose name is Claire Folsom. And so King, again, the negotiator that he is, tells Claire that he wants to learn real lab infectious disease biology, so real microbiology. And Claire is happy to have somebody, a former mentee of his. He's like, yep, absolutely, let's do it. So pretty soon, given the nature of the war, King ends up in Philippines in a place called Subic Bay. Now, Subic Bay at that time, in the middle of the Vietnam War, is sort of this bustling place. You have ships coming in and people coming in, and sort of a real, let's say, a dynamic and a bustling sort of bay at that time. Now, what he starts to see is that a large number of naval officers are being diagnosed for gonorrhea. And the doctors, knowing what they knew at that time, were prescribing penicillin. And half of these sailors were not responding to the penicillin. And so King wears his detective hat and says, what's going on? So he takes the samples from these sailors, and the first thing he finds is that half of them were not even gonorrhea. They were similar in terms of their symptoms, but they were non-gonorrheal urethritis. So penicillin wasn't going to do anything. So half of the people were not responding, were not even getting the right drug. The other half that were giving gonorrhea, that did have gonorrhea, were also not responding very well. So something wasn't adding up. So he goes to the city, to a place called Olongapo. Right, and the first thing he sees is that there are sort of these people, these sex workers and others, and they go to this one doctor in town, and she has no sanitation mechanism. So she uses the speculum for all of her patients and sort of dips them in a bucket of water and uses it on the next person. Right, so that was the first sign of something of sort of the spread of infection. But it doesn't answer the resistance thing. It only tells you that there's infection that is spreading. So now you have this issue that, yeah, infection is spreading. Some of it is gonorrhea, some of it is urethritis. But why are they resistant? What's going on? So he goes back and asks the doctors, what are they prescribing? So at that time, you have two kinds of penicillin. One is called benzathine penicillin, and one is procaine. All of them were given procaine. Yeah, so all of them were given benzathine penicillin. Now, benzathine penicillin is very good for syphilis, but what it does is a low dose stays in your system for a long period of time. Procaine goes up sharply, a high dose, and then comes down quickly as well. And so what they were getting were sort of basically a dose of benzathine penicillin that stays in the system, allows the bacteria to become resistant, and nothing happens. So he says, well, there's another problem, right? So you have problem number two, you're getting the wrong drug. Half the people are getting the wrong diagnosis. Other half are getting the wrong drug. So he really now is your full-time detective and a policymaker at the same time. So he works with his superiors to get 250 different specula and an autoclave machine on the vessel so that all of these things can be cleaned and come back to the town. He also sort of puts a gram staining protocol so that you can tell which one is non-gonorrheal, gonococcal urethritis, and which one is gonorrhea. And then the third thing that he does is he says you need to change the dosage. You need to give these people procaine and also a sort of a drug that goes with it so that it stays in the system at a high level and really clears the bacteria. What is remarkable is that what he did in late 60s is still the policy today, 50 years later. So that's the beauty of doing thoughtful, rigorous research, even with very limited resources, that becomes a policy, not just for US Navy, but for the entire world. And King is a delightful person. I didn't even know about this story. I had known King because of my work in global health well before this story, but this is just one of the many people, sort of these remarkable heroes and heroines of science who changed things because they saw something that wasn't adding up in their immediacy, in the people who they were responsible for, right? So these people are not the heads of NIH or heads of large agencies. They are on a ship where they're seeing that people are not getting better, and sort of really using the tools of science to make an impact. And that's, I think, just absolutely inspiring.
Oh, that's terrific. And so, to follow on that theme, you're probably aware that we have a regular, what we call battle rhythm of global health engagements, within the Navy, as does the Air Force and the Army. We tend to send out our hospital ships on a regular schedule, and they engage. And so, given your findings in the book and your awareness of how we operate, what are the implications, or what are your recommendations for how we can contribute to resolving antibiotic resistance as we go into these global health engagements?
When I started working in global health, I used to go to this. I still go to this meeting called American Society for Tropical Medicine and Hygiene, and I would see a lot of people in the naval uniform, and I had no idea why they are there, right? So all of my other conferences, you see a few people in uniform, but this sort of tropical medicine meeting, and you see sort of these people who are literally at the forefront, all the way from sort of the far reaches of the Pacific to the tropics in Africa and elsewhere. And I started talking to them, and what I realized is that in some ways, these people are your sort of eyes and ears on the ground well before anybody else, right? So they are seeing things in communities in ways, and I think that's a sense of responsibility that I hope your colleagues will have, is that not only are they sort of serving the nation, they're also serving the world in a broader sense by being aware of what is happening in terms of disease surveillance. So that's something that I have learned, and I've looked at the archives all the way from the archives of the Second World War to more recent ones, and you find in letters and other sort of reports that they are seeing things well before anybody else. And of course, some of them may have national security implications, but many of them do not. And so that contribution, that sense of responsibility, is I think I hope your colleagues will feel that they are really on the forefront more than in one way. And here they're on the forefront of disease as well. So that's the first thing. The second thing I think, which would be fascinating, is to understand, because your servicemen and women are in these places, to understand why some of these problems persist. Why do they originate? Is that something in sort of the climate, in the behavior, in the engagement? As we saw from the story of King Holmes, that it wasn't just science, it was sort of how the society was operating and the practices that allow for these things to perpetuate. In the story about this Acinetobacter, and you were part of the mission in Iraq, it was again a combination of sort of factors on the ground. I mean, these things don't happen in a vacuum. So that recognition that there are ground realities that really manifest themselves, that allow you to sort of report that. I mean, if you look at some of the earlier reports in sort of military medicine journals, they demonstrate very clearly what is happening with the Acinetobacter resistance, so that to the point that it gets to the U.S. Congress. And I think, again, a recognition of the complexity of things on the ground, because these diseases, whether it is a bacterial infection or a viral one, whether it starts in Wuhan or elsewhere, these are coming out of certain practices, whether it is sort of a wet market in Wuhan where sort of it goes from meat to humans or elsewhere. That, I think, is very, very important. And the third thing, I think, which is perhaps the best part, of which I have learned to appreciate, is being true to good, rigorous research, not driven by any mission except for mission of curiosity. There are many stories, the story of development of ORS and sort of the work that Navy did in the 1950s in that, and sort of the reports that are coming in the Korean and the Vietnam War. I think there were a lot of outstanding work done by naval clinicians and medics that really formed the basis of new discovery. So I think some of the things that we don't appreciate is that they're not sort of just medics, they're also in some ways your best detective scientists who have done some fundamental science work. People may not use penicillin on a day-to-day basis in Boston or in DC, but the fact that it becomes part of the overall treatment guidelines of WHO tells you that there is basic discovery that has gone on. And I think if they continue to wear that hat in addition to many other things that they do, that would be just phenomenal.
Oh, that's terrific. And I think you're aware that, you know, our overseas labs do participate in the WHO, CDC global emerging infectious disease network. So we do have that opportunity. I do think there's an opportunity for the capacity building for those host nations that we interact with in both directions, and we've certainly found that. I'm really taken by that mission of curiosity. I like that phrase. The other phrase that I think gets at one of the key themes in your book was the idea of access versus excess. Could you expand on that for the audience?
Yeah. So I think one of the things that we have not done well is somehow thought that bacteria are the enemy, that all bacteria are bad, or sort of this notion that this is some kind of a war on bacteria. So first, I want to push back on that common notion, because you and I and our families wouldn't be able to survive or develop if it wasn't for our good microbiome. It is fundamental for immunity, it's for development, it's for digestion, it's for mental health, all of that, right? So this notion, the fact that you have probiotic yogurt in your supermarket tells you that this is not some kind of a battle lines that we need to draw against people and bacteria. So that's the first part. The second part of that argument is also important, is that more people today die because they do not have access to frontline antibiotics when they need them for basic infection than people who die because of excessive antibiotic use and development of resistance, right? So the earlier argument of moderation and balance is critical here. If somebody has an infection that can be cured with azithromycin or penicillin or ampicillin, and the fact that that individual, because of his or her socioeconomic status or poverty or whatever, doesn't get that drug and ends up sort of dying because of that, that is just as unacceptable as any other sort of crime. So so the first part we have to understand is a vast majority of the world, including places where your colleagues serve, do not have access to frontline antibiotics. So that's one problem. The other problem is that there are other parts of the world, even in those countries, where antibiotics are used excessively when they shouldn't be, right? So it's animal agriculture, it's over-the-counter prescription, it's the fact that you are giving it prophylactically for a variety of other reasons. So that tension is where the problem lies. A group of people doesn't get it when they need it, another group of people uses it when they don't need it. So again, what we need is better diagnostics, rational policy, and of course, lots and lots of awareness. As you said, capacity building in both directions, but also, as I often tell people, that the problem is not going to be solved in some laboratory, but sort of a collective human understanding and awareness and interaction. That is, I think, absolutely critical here.
Very good. Well, thank you. And the other kind of one of the key challenges is the role of industry, and you described the fact that many major pharmaceutical manufacturers have actually gotten out of the business of producing antibiotics because there's no return on investment, maybe even a negative return on investment. And so is the answer, does government have a role? Is there a philanthropic role? You mentioned the Gates Foundation. How do you see that playing out? Because clearly, there hasn't been, as you point out in the book, really haven't been any significant development of new classes of antibiotics in many years. So where do we go from here?
Absolutely. Admiral Gillingham, if I had told you 18 months ago that I had a vaccine for a novel coronavirus, the value of that would have been exactly $0. So the market-based system doesn't always work for infectious diseases, right? And if you are a head of a publicly traded pharmaceutical company and you go for antibiotics that are the government will say, well, great job, but you can't sell it because you want to hold it for an extreme case. That doesn't sound like a good business model, right? So you make all these investments and somebody says, well, you can't sell it unless there's an extreme emergency, versus a cancer drug or a cardiovascular ailment or a neurodegenerative disorder or anything, or blood pressure, where somebody has to take it every day for decades. The economics doesn't quite add up. So I think the solution is going to lie in many cases, and we're seeing some of that with the current COVID vaccines, where the government gets involved and says, there are rewards to enter the market, right? So you sort of share some of that risk early on and say, okay, if I were to invest this, how do I recoup my money? Profit is the second thing, but even that I have that investment returns. We haven't really seen all of that as much as we would like to, but the current COVID sort of model, not just in the US, but elsewhere as well, where there's an incentive to develop something from public financing or public-private partnership, that's one way to do that. So those are market entry rewards. The second one, I think, is also how do you de-risk some of that? And so the early stage part is the most risky, where you have lots of leads and most of them don't pan out. Can that be sort of really outsourced in a way that can be changed? Now, at the same time, I also believe strongly that just because pharmaceutical companies are not interested doesn't mean that they come in and reap the rewards at the end and have an exorbitant prices and nobody gets to have it, right? So you need to sort of have checks and balances at that stage as well, and make sure that those things are affordable. One other thing, and again, there are some models to look at, is how do you define antibiotics as a public good? And there are different models to look at that. And that doesn't mean that you basically have a single payer healthcare system, but that means that you define certain things where there are, for example, as we know with the COVID vaccine, the government is making sure that people get it because it's a public good, right? So only if you imagine a situation, only a few people got it who could afford, that wouldn't actually work, because there are a whole bunch of people who will still remain vulnerable, and that is actually very problematic. But if you define of it as a public good, then you can start to sort of change things as well. So there are various kinds of economic models. Unfortunately, we haven't seen as much movement on those as we would like. But there is some reason that to hope. There is some money coming in from BARDA, where the DoD is involved with the NIH for early stage diagnostics and some early stage funding as well. And I think the models are where equity will not be owned by the investors, but by the company. So you sort of invest as a grant as opposed to invest as a VC firm. So there's some room there, but in general, I think that is one of the things where we are most concerned, that large industry that has the intellectual power to create these antibiotics are not seeing as much movement from business models as we would like them to.
Yeah, quite a challenge. Well, thank you. That was a great explanation. And so it asked me, I mean, it kind of leads to the question: can we leverage some of the, artificial intelligence and predictive analytics and those sorts of things to perhaps speed the discovery of new antibiotics?
That's a great question, Admiral. And the people I spoke to who are in the business of discovery, despite sort of the challenges, they remain not just cautiously optimistic, but very optimistic. And they're optimistic for multiple reasons. One, they think that there is a vast untapped resource in nature. You find new antibiotics in sort of the soil right outside sort of rural Ontario or in Latin America and elsewhere. So there is that hope that nature has these huge reservoirs that we haven't tapped into. That's one. And the second one, which I think allows us to increase the runway of antibiotics for a little while, is new combinations of existing antibiotics that give us sort of the synergistic effect that allows us to be a step ahead of the pathogen. And there, I think the new data-driven approaches can be very useful, because one, they cut costs, and two, you're able to really increase the portfolio of possibilities. So one of my colleagues, and there's a chapter about him, Jim Collins, who's at MIT and works in the area of synthetic biology. He and others have sort of developed these artificial intelligence algorithms that have started to mine existing antibiotics and sort of thinking about whether there's an opportunity. Because right now we're in a situation where we want to sort of increase the runway so that human behavior, new antibiotics, vaccines, phage therapy, all of these can come in and allow us to sort of have a little bit of a breathing room. And I think there's the opportunity. And I think both of them together also have the possibility, as we mine more molecules, certainly do so in a way that is environmentally sustainable and respectful of nature, but to be able to see some of those, you might be able to cut some of the costs that are there. And again, that's a lesson from history, because the great discovery in penicillin came from a rotten cantaloupe outside Chicago, not from some great distances. And then people had been sort of sending soil samples from all over the world to Eli Lilly and Merck and elsewhere. So there's tremendous hope for that as well.
Yeah, that was a fascinating story in the book. The other, I guess I'd look at the other side. So will further understanding of bacterial defense mechanisms be helpful? Certainly the progress that we've made in genomics in general, are there opportunities to apply that to manipulation of the bacteria as a therapeutic?
So that's a great question as well. And I can tell you've read the book with great detail, Admiral. So this is great. One of the things that has been interesting is, can you sort of do things at the bacterial level, either in reprogramming bacteria or in sort of slowing down evolution? So that was the work of Dr. Huram Marikh, who's now at Vanderbilt, in sort of thinking of genomic pathways that can be altered, and can you slow down sort of evolution, because of course this is an evolutionary process. But then there's the other angle, which I think is also very interesting. The whole notion of phages, of which phage would work, is also trying to understand the viral bacterial interaction, the interaction of viruses that are able to commandeer the bacterial machinery and allow it to sort of lyse. So I think basic science is absolutely critical. And one of the things that I tell people all the time is that while we want to see more therapeutics and more diagnostics, they all stand on the shoulders of basic science. Even the mRNA vaccine today that we are excited about for COVID stands on basic science. So that investment, and I'm reminded that investment is really and one that is one of the most robust vehicles of investment, as Francis Collins from NIH will tell you, that remains in medical sciences the best investment we ever made is in basic sciences. It pays better than anything else. So understanding of bacterial genetics and small changes in the genome, interaction of viruses, interaction of pathogen with the host. So what happens in the test tube in my lab versus what happens in the gut may or may not be the same. Those things, I think, are essential for us to really have an arsenal of new therapeutics.
Well, that's terrific. And I'm just as an aside, that the story about Dr. Marikh was incredibly inspiring to me. And as we look at issues within the Navy of diversity and inclusion, I couldn't think of a better example of someone coming from a background, a very, very impoverished and challenging background, that and the contributions that she's making, given her ability to seize the opportunities that were provided for her. So thank you. That was a very her biography or her profile stood out as one of my favorites in the book. And then just finally, so that you're aware, my audience hopefully is aware that I have 4 strategic goals, and they go this way. They're people, so highly trained people who are operating on what we call platforms, be it our hospital ships, be it our expeditionary hospitals, be it our medical treatment facilities, using high reliability, high performance behaviors, so that 3rd P, performance, to produce medical power in support of the Navy and the Marine Corps. And so given that framework and my preamble that I've put each of the books in one of those categories, so people, platforms, performance, or power, where would you like me to place this book?
I think if it can be placed both in people and performance, partly because the story is of remarkable people. One of the things that I deeply, deeply enjoyed was meeting people all across the world. Somebody who was in his late 80s in sort of northern Norway and opened up his home, and I spent the entire day with him in trying, and again, his father was actually in Norwegian Navy as well in the Second World War.
Right. Right.
And so it's the people who really have stood up through their remarkable creativity, men and women in countries, in pretty much every single sort of continent, whether it's Australia or Africa. So I think that sense of inspiration is what gives me hope in both the goodness of the people, but also the fact of their remarkable ingenuity and creativity for a common cause, for the choices we make for everybody to have a more decent, a more healthy life, to be able to make a contribution. And one of the things that I learned was I didn't even have to sort of look for diversity. It was just happening all around me.
Mm-hmm.
I didn't have to go and search for people from different backgrounds, socioeconomic or cultural. If I paid attention, it was as diverse as the world itself, and that was just absolutely inspiring. Of people sort of without any goal of fame or fortune were doing it because this was a problem that was driven by curiosity and because they wanted other people to have a good, decent, healthy life.
Well, very well. Okay, so you've made a strong case, and so we'll take that into consideration as we put it on the list. Well, Dr. Zaman, we so appreciate your time today, your generosity as I said, our inaugural author for the SG's Meet the Authors series. And I will say that, I think for the audience who are deciding whether they want to read the book, I will tell you that if an orthopedic surgeon can get as engrossed in the book as I did, it's incredibly readable. It's very inspiring. The history is very palatable and very much reinforces the themes in the book. And so I felt like my understanding of the issue of antibiotic resistance, but also medical discovery, the important role of, if you will, cultural anthropology and understanding these medical issues. And that's a plug to my background as with a major in cultural anthropology in college. So I have to be honest to that, true to that. But sir, thank you so much for your time. It's clear that in addition to being a world-renowned biomechanical engineer, author, you're clearly a humanitarian, and we appreciate your example and the time that you've shared with us today. So thank you very much.
It's a pleasure, and as I said at the beginning, I owe a lot to my success to colleagues in the Navy for setting me on the path of discovery and learning and understanding. So it's deeply appreciated.
Oh, awesome. Well, thanks. Well, good luck, sir, in your efforts. Look forward to seeing your work continue to develop as you go forward.
Thank you so much. Thank you so much.
Okay. Goodbye.
Bye-bye.